This presentation provides an overview of weight stigma, its negative effects on health, how it interferes with effective patient care, and strategies that can be implemented to reduce weight stigma and improve supportive healthcare delivery to patients of diverse body sizes. In our society, people are quick to judge others based on their physical appearance. This is especially true when it comes to body weight. Individuals who have a high body weight or large body size are often judged, criticized, and blamed for their weight. This societal devaluation of people because of their body weight is called weight stigma or weight bias. At the foundation of weight stigma are strongly ingrained societal stereotypes about people with higher weight. Often, negative public attitudes reflect a limited understanding of the many factors beyond food intake and physical activity that contribute to body weight, including genetics, biological factors, and environmental factors. Some of the most common stereotypes in our society include assumptions that people who have higher weight are lazy, lacking self-discipline, have poor willpower, are unmotivated to improve their health, and personally to blame for their weight. These stereotypes set the stage for weight-based bullying, rejection, prejudice, unfair treatment, and discrimination. The prevalence of weight stigma and discrimination is high among American adults. National U.S. studies show that approximately 40% of American adults have experienced some form of weight stigma in their lives, whether it is in the form of teasing, bullying, or mistreatment. For people who have obesity, prevalence rates of weight discrimination, such as being treated unfairly in the workplace or facing weight-based inequities in education, range from 19 to 40%. Rates of weight discrimination are typically elevated for people with the highest weight status or BMI. Who is most likely to experience weight stigma? Weight stigma affects women and men of all ages. Women tend to report higher rates of weight stigma and experience it at lower body weights compared to men. Weight stigma also affects people across different racial and ethnic backgrounds and different sexual and gender identities. Although stigma tends to be most common and harshest towards people at the highest weight categories, people can face weight stigma at different body sizes. And weight stigma is by no means unique to North America. It is present in countries around the world. For many people, weight stigma is a lifelong struggle. The experience of weight stigma is not restricted to a certain age or time period. It can be present and persist throughout a person's life. Research shows that negative weight stereotypes are expressed early on in childhood. Children as young as 3 years of age ascribe negative characteristics to their peers with larger body sizes. These attitudes become strongly ingrained over time. So for individuals who have a high body weight as a child or adolescent, weight stigma begins in the form of teasing, bullying, and rejection in youth, but expands over time to include unfair treatment and discrimination in adulthood. Thus, many adults who experience weight stigma have been enduring stigma for many years. Where does weight stigma occur, and what does it look like? In our society, there is no place where a person is protected from or immune to weight stigma. It remains legal almost everywhere in the U.S. and the rest of the world to discriminate against people because of their weight. And because weight stigma is rarely challenged in our society, it remains commonplace in many societal settings. For example, in the workplace, weight stigma negatively impacts job-related outcomes. Qualified employees with higher weight are less likely to be hired than thinner employees. At their jobs, they face negative weight stereotypes from coworkers and supervisors, fewer recommendations for promotion, and lower salaries, as well as wrongful job termination. In the media, weight stereotypes are common in movies, television, news, advertising, and across social media platforms. For example, television shows and films depict characters with larger body sizes in stigmatizing ways, reinforcing negative stereotypes and judgment of people based on their body size. The news media often oversimplifies the causes of obesity, typically ignoring the complex contributors and emphasizing personal responsibility. Shaming people for their body size is also commonplace on social media platforms with little or no sanctions for hateful speech. In close interpersonal relationships with family members and friends, weight stigma can also be present. For example, children and adolescents with higher weight face weight teasing, judgment, and stigma from parents, siblings, and other family members. This can lead to harmful consequences for their health and well-being, such as psychological distress and disordered eating behaviors, especially because weight stigma within families often persists into adulthood. In healthcare, adults with high body weight commonly report stigma from medical professionals, reducing the quality of care they receive and leading to avoidance of healthcare. Negative weight stereotypes are expressed by healthcare professionals across different specialties and contribute to poor clinician-patient communication and patient outcomes. Taken together, this evidence shows that it's difficult to escape weight stigma in one's daily life. It can occur in subtle or overt ways almost anywhere. Given the high prevalence of weight stigma and its presence throughout our society, it's important to understand how these stigmatizing experiences can negatively impact people's health. Substantial research evidence demonstrates links between weight stigma and adverse health behaviors and outcomes. This includes psychological distress like depressive symptoms, maladaptive and disordered eating behaviors like binge eating, reduced physical activity, increased physiological stress and metabolic risk factors, and weight gain. Let's look at each of these more closely. First, weight stigma creates considerable emotional distress for people who experience it. Being shamed, stigmatized, or treated unfairly because of one's body weight or size can lead to an increased risk of depressive symptoms and anxiety, lower self-esteem, poorer body image, increased levels of substance use, and even suicidality. For example, higher levels of suicidality have been documented in individuals with high BMI who have experienced stigma or bullying compared to same weight peers who have not experienced this stigma. The psychological distress of weight stigma has been documented in both community samples and clinical treatment samples of adults, and these emotional consequences persist after accounting for BMI. This is important because it tells us that it's not body weight or obesity itself that is leading to this psychological distress, but rather it's the experience of being stigmatized for one's weight. The emotional toll of weight stigma on mental health is very damaging, especially when we consider that weight stigma can come from close family members and friends, so those close relationships are not necessarily available for emotional support, which can worsen their distress. Beyond impairing psychological well-being, weight stigma can also affect physical health. An unexpected finding that has emerged consistently in prospective research studies is that experiencing weight stigma predicts weight gain and obesity over time. This has been demonstrated in younger people and adults. Two examples are highlighted here. First, the figure on the left summarizes findings from the Project EAT study, which is a longitudinal cohort of almost 2,000 adolescents that have been followed for 20 years from mid-adolescence through their 30s. Research from this cohort found that both girls and boys who were teased about their weight in adolescence were more than twice as likely to have obesity 15 years later in their mid-30s compared to their peers who were not teased about weight. These analyses were controlled for baseline weight and sociodemographics. In the example on the right, data are from 2,944 men and women aged over 50 years in the English Longitudinal Study of Aging. Weight and waist circumference were objectively measured in 2008 and again in 2013. Perceived weight discrimination was associated with increases in weight and waist circumference and higher odds of developing obesity over the follow-up period. Again, these findings persisted after accounting for baseline body weight and sociodemographic factors. Other forms of discrimination, such as race or gender-based discrimination, don't seem to have these same consistent effects on weight gain. It appears to be more unique to weight-based discrimination. And these patterns of weight stigma contributing to weight gain over time are present in youth and adults. This evidence has helped us understand weight stigma not only as a psychosocial consequence of obesity, but also a psychosocial contributor to obesity. So a key question from this evidence is, why does weight stigma promote and contribute to weight gain? What are the mechanisms? What we see from research is that people who experience weight discrimination are more likely to engage in behaviors that promote weight gain. For example, evidence consistently shows that weight stigma is associated with unhealthy eating behaviors. In particular, binge eating has emerged as a common correlate of weight stigma. There are also links with weight stigma and increased food consumption, unhealthy weight control practices and maladaptive eating patterns, and emotional overeating. And specifically, people who experience weight stigma have a higher prevalence and frequency of these unhealthy eating patterns. These links have been documented in both community and clinical samples of adults. One of the reasons why these maladaptive eating behaviors are observed in people who experience weight stigma is that individuals may cope with the emotional distress of weight stigma by turning to food. 2 examples are highlighted in this slide. One of the first studies to examine this, back in 2006, studied 2,400 women enrolled in a self-help weight loss program and examined how they coped with weight stigma that they experienced. Women reported using many different coping strategies. Some were positive and some were negative. But a striking finding was that 79% reported that they tend to turn to food as a coping mechanism, that eating temporarily relieved their distress of being stigmatized. This aligns with what we know from research in psychology, that eating is a common coping strategy in response to stress. Food can activate dopaminergic reward pathways in the brain and provide some temporary relief from the negative emotional effects of being stigmatized. Given that weight stigma is a stressor and a chronic stressor for many people, it's not surprising that increased food consumption is a common coping strategy. Similar findings have continued to be documented as summarized on the right side of this slide. This provides more recent evidence from a national community sample of 2,400 U.S. adults, where it was found that the more weight stigma people reported, the more they coped with stigma by engaging in disordered eating behaviors and increased eating and food intake. We also see that these coping responses become long-term patterns, as prospective research with adolescents has found that those who are teased about their weight are more than twice as likely to use food to cope with emotions 15 years later in adulthood compared to their peers in adolescence who were not teased about weight. In addition to unhealthy eating behaviors, we've seen that when people experience weight stigma, they are less likely to engage in physical activity and exercise. In adults, experiencing weight stigma can induce negative feelings about engaging in physical activity, lower intentions to be physically active, and avoidance of exercise. This can happen because physical activity settings are often places where people feel more vulnerable to being stigmatized or shamed about their weight, and so they cope with those experiences by avoiding them. The chronic stress of weight stigma may also contribute to weight gain through dysregulation of the hypothalamic pituitary adrenal axis. People who experience weight stigma have been found to have elevated levels of cortisol and C-reactive protein, as well as higher blood pressure and higher A1C levels. Importantly, these findings persist independent of adiposity, which again tells us that it is the experience of weight stigma that is increasing these physiological responses. This evidence also includes higher inflammation markers among people who experience weight discrimination and a twofold 10-year risk of high allostatic load, or cumulative burden of chronic stress on the body for adults who experience weight discrimination compared to those who do not. Studies also demonstrate that weight discrimination amplifies the relationship between abdominal obesity and A1C levels and mediates prospective associations between obesity and physiological dysregulation. Taken together, this research highlights the stress-induced health consequences of experiencing weight stigma, which can trigger an obesogenic process through physiological and biochemical pathways. Furthermore, studies using national samples of adults demonstrate a 60% increased risk of dying for people who report experiencing weight discrimination, independent of BMI, suggesting weight stigma may even contribute to all-cause mortality. Even if people don't experience weight stigma directly, being exposed to weight stigma that we see in the media can also have negative implications for physiological stress. 2 examples of experimental studies highlight this here. In one study, summarized on the left, women of different body sizes were brought into the lab in individual sessions where they were randomly assigned to one of 2 conditions. In one condition, they watched a 10-minute video depicting clips of neutral advertisements unrelated to weight, and in the other condition, they watched a 10-minute video consisting of clips from popular television shows and films in which female characters were stigmatized or made fun of for their weight. Participants' salivary cortisol was assessed both before and after watching either the weight stigmatizing or neutral video. Baseline cortisol levels did not differ between the groups, nor did demographic characteristics. Women who watched the stigmatizing video had significantly greater cortisol reactivity compared to those who watched the neutral video, irrespective of their weight status, showing that women found the stigmatizing clips to be stressful to watch even if they don't have a high body weight themselves. These findings persisted after accounting for minutes since waking, days since last menstrual cycle, age, body mass index, stress, and depression. In a different study, this time a randomized trial with women who have obesity and high blood pressure or normal blood pressure, researchers assessed the influence of two different video exposures depicting either weight stigmatizing or non-stigmatizing scenes from popular television shows and films on cardiovascular reactivity. As summarized on the right side of the slide, it was found that laboratory systolic and diastolic blood pressure increased significantly more in women with high blood pressure than normal blood pressure after watching the Stigma video versus the neutral video. In addition, ambulatory blood pressure and heart rate increased more among women with high blood pressure over sleeping periods following the Stigma versus neutral video. These findings provide evidence that weight stigma increases cardiovascular reactivity among women with obesity and high blood pressure, both in the laboratory and under ambulatory conditions. This experimental evidence can help explain recent studies documenting links between weight stigma, metabolic risk factors, and cardiovascular disease. For example, recent research shows that weight stigma is associated with higher odds of meeting criteria for metabolic syndrome. In addition, adults who experience weight discrimination are at heightened risk for cardiovascular disease and myocardial infarction. So we can think about weight stigma as a modifiable risk factor for poor cardiometabolic health. Besides maladaptive coping responses to stigma, another way that weight stigma may contribute to poor health is how people interpret stigmatizing situations through a process known as internalization of weight bias. When people experience weight stigma, the negative societal judgments that they face can become an internalized process of negative self-judgment and self-blame. Internalizing weight bias happens when people are aware of weight-based stereotypes, apply these beliefs to themselves, and engage in self-directed stigma and personal blame. Internalized weight bias is fairly common in the general population. National studies have found that about 1 in 5 people have high levels of internalized weight bias, with estimates of over 50% among people who have obesity. This is especially likely among women with high BMI who are trying to lose weight. Internalized weight bias is relevant for health because research shows that it can have the same negative consequences for eating behaviors and weight-related health as experiencing weight stigma. In fact, research is increasingly showing that internalized weight bias predicts poor health over and above the experiences of stigma or unfair treatment itself. And these links remain after accounting for people's body size and how much stigma they've experienced. Several studies have specifically examined the implications of internalized weight bias for weight management. One example is highlighted here, conducted with a national community sample of U.S. adults who had lost at least 10% of their weight in the past year. Some adults had maintained that weight loss, while others regained it. In looking to see what role stigma might play in these outcomes, it was found that typical behaviors linked with sustained weight loss, like dietary monitoring and self-weighing, were not significant for these groups, but there was unique predictive value of weight stigma, and specifically internalized weight bias, when it came to who maintained versus regained weight. Specifically, as levels of internalized weight stigma increased, the odds of maintaining weight loss decreased by almost 30%. This evidence suggests that the internalization and self-blame resulting from weight stigma may interfere with people's efforts to maintain weight loss, regardless of how much weight stigma they've experienced. Another example comes from a large U.S. study with adults engaged in weight management. Internalized weight bias, but not experiences of weight stigma, was associated with lower odds of weight loss, higher odds of weight gain, and poorer weight management behaviors. And these findings persisted after controlling for participants' BMI and sociodemographic characteristics. So this shows us that internalized weight stigma is potentially creating barriers for adults engaged in weight management. Taken together, this evidence reiterates the role of internalized weight bias as a contributor to poor weight-related health. And these patterns may be occurring in part because of links between internalized weight bias and how people cope in response to weight stigma. That is, among adults engaged in weight management, those who internalize weight bias tend to use more maladaptive coping strategies in response to weight stigma, such as engaging in disordered eating and avoiding exercise, and also tend to use fewer adaptive coping strategies like seeking social support or engaging in positive self-talk. In summary, this collective evidence demonstrates the ways in which weight stigma may ultimately contribute to weight gain and obesity. The psychosocial distress of experiencing weight stigma can lead to maladaptive coping strategies to deal with this distress, as well as internalization or self-stigma, both of which reinforce unhealthy eating behaviors and other risk factors like dysregulated physiological reactivity, which can contribute to weight gain. This can ultimately create a harmful cycle because increased weight gain makes a person more vulnerable to experiences of weight stigma, which sets this pathway in motion again. In this sense, it's helpful to think about weight stigma as both a psychosocial contributor to obesity and a psychosocial consequence of having higher weight. The numerous links between weight stigma and health have led to an increasing recognition of weight stigma as a public health issue, including an international consensus statement endorsed by more than 100 professional societies calling attention to the harms of weight stigma and the importance of addressing this problem. The medical community is a critical setting where this recognition is needed, as healthcare professionals play an important role in addressing the health harms of weight stigma in their patients and providing them with supportive and compassionate care. However, to effectively address weight stigma, this requires an understanding of how weight stigma can be present in the healthcare setting and negatively affect patient care. Researchers have studied weight stigma in the healthcare setting from the perspectives of both clinicians and patients, and this evidence highlights a complex and prevalent problem that creates barriers for effective patient care. Several decades of research have documented weight-biased attitudes and stereotypes among healthcare professionals towards patients with higher weight. Stigmatizing attitudes of medical professionals include views that people with higher weight are lazy, lacking motivation, have poor self-control and no willpower, are at fault for their weight, have poor self-management behaviors, and are less compliant with medication and treatment. These attitudes have been reported by a range of healthcare professionals, including doctors, nurses, dietitians, obstetricians, mental health professionals, physiotherapists, occupational therapists, exercise physiologists, and by students training in professional health disciplines. Moreover, evidence indicates that doctors express implicit and explicit weight bias at similar levels to the general population, and that weight bias is even present among healthcare professionals who specialize in obesity. This evidence reiterates that medical professionals are not immune to societal weight stigma, and even if unintentionally, may be expressing this bias in clinical care. According to the perspectives of patients, stigmatizing attitudes from healthcare professionals are quite common. In fact, some research suggests that adults with higher weight view doctors to be one of the most common interpersonal sources of weight stigma in their lives, with approximately 1/2 to 2/3 reporting that they have been stigmatized from a doctor. As an example, several study findings are highlighted in this slide, depicting different samples of adults with high body weight, including adults engaged in weight management, adults with type 2 diabetes, and patients undergoing bariatric surgery. When asked about their experiences of weight stigma from a healthcare professional, you can see high percentages of people across these studies report weight stigma from doctors, nurses, and other healthcare professionals. In some cases, weight stigma from doctors was reported by about 2/3 of study participants. Collectively, these studies tell us that patients are aware of biased attitudes in their healthcare professionals and perceive stigma from them. Clinician weight bias can translate into poor communication with patients and reduced quality of healthcare delivery. Research examining clinical care practices of healthcare professionals shows that compared to their provision of care of patients with lower BMI, that when it comes to their interactions with patients with high BMI, clinicians tend to spend less time in appointments, demonstrate less rapport with patients, engage in less patient-centered communication, engage in less discussion and intervention, as doctors admit that they don't intervene as much as they think they should, and report lower respect for patients as their BMI increases. So it's not surprising that patients who feel disrespected or judged about their weight have lower trust in healthcare professionals and are reluctant to discuss their weight and perceive their weight as a barrier to getting appropriate health care. Patient reports of weight stigma from healthcare professionals commonly include feeling judged or shamed because of their weight, receiving disrespectful or insulting comments, and general lack of compassion during healthcare visits. As an example, a systematic review of qualitative studies examining patients' perspectives of clinical encounters about obesity identified commonalities in their experiences with professionals, including negative judgment of patients due to their weight, insensitive language about weight, banal weight loss advice, assumptions that patients have unhealthy lifestyles or are not trying to address their weight, and assumptions that patients' symptoms were due to weight without a proper history or examination. Patient perceptions of weight stigma in primary care can influence their engagement with primary care services. A scoping review of 21 studies examined patient perspectives of their primary care experiences. In addition to clinicians' stereotyped assumptions about obesity and their attribution of all health concerns as weight-related, patients also reported disrespectful treatment from healthcare professionals, anticipation that they would be treated differently or unfairly due to their weight, lower trust and poor communication in the clinician-patient relationship, ambivalence about using health services, stigma-related barriers to healthcare utilization, such as not wanting to be weighed or inadequately sized medical equipment for their body size, doctor shopping as a result of experiencing weight stigma in healthcare, and avoidance or delay of healthcare services due to weight stigma. Other research also suggests that with each increase in a patient's BMI category, there is approximately a twofold increased likelihood of perceiving stigma in primary care. Collectively, this evidence highlights how patient perceptions of weight stigma from primary care health professionals can negatively affect their engagement in primary care. Of particular concern is increasing evidence showing that weight stigma contributes to patient avoidance of healthcare. Some of the first research in this area examined healthcare experiences of women with higher weight, depicted on the left panel of this slide. In this study, women reported that experiencing weight stigma in healthcare created barriers that contributed to their delay and avoidance of gynecological healthcare and preventive health screenings. These barriers included disrespectful treatment and negative attitudes from healthcare professionals, unsolicited advice to lose weight, medical equipment that was too small to be functional for their body size, and embarrassment at being weighed. The percentage of women who reported these barriers increased as their BMI increased. More recently, researchers have examined the specific ways in which weight stigma contributes to healthcare avoidance for adults with higher weight. The right side of this slide summarizes a study of over 2,000 primary care patients with higher weight. Researchers found that patients' stigmatizing experiences in healthcare and lower patient-centered communication mediated the associations between patient BMI, delaying care, and changing doctors. Moreover, lower perceived respect from professionals mediated the association between patient care experiences and healthcare utilization. This suggests that patients with higher weight may feel less respected because of the stigma they experience and receive poorer communication from healthcare professionals, leading them to delay future care or to seek different healthcare professionals in hopes of avoiding additional stigma. A common theme in both of those studies is that stigmatizing communication from healthcare professionals contributed to patient avoidance of healthcare. And in fact, evidence suggests that patients explicitly intend to avoid future care if they feel stigmatized about their body weight by their doctor. Shown on this slide are two studies that surveyed national samples of adults with diverse body sizes about how they would react if their doctor referred to their weight or their child's weight in a stigmatizing way. As you can see here, about 1/5 of adults and 1/3 of parents said they would switch doctors if this happened to them, and about 1/5 of adults and 1/4 of parents would avoid future medical appointments for themselves or their child. These findings suggest that stigmatizing communication from healthcare professionals has concerning implications for healthcare utilization. Emerging evidence suggests that healthcare avoidance may also have important links with patients' internalization of weight bias. Several examples highlight these links on this slide. First, in a study of women shown on the left panel of this slide, internalized weight bias was related to greater body-related guilt, which was associated with higher body-related shame. Body-related shame was in turn associated with healthcare stress, which contributed to healthcare avoidance, independent of women's age, income, and the presence of illness. Second, the center panel of this slide reflects findings from a large sample of adults engaged in a commercial weight management program. It was found that those with higher levels of internalized weight bias were more likely to avoid healthcare, obtained less frequent routine checkups, and perceived that their doctors were negatively judging them about their weight, and had less respect for them and didn't listen to their needs. Overall, they perceived the quality of their healthcare to be worse compared to adults with less internalized weight bias. These findings controlled for demographics, BMI, and experienced stigma of study participants. Finally, in a sample of adults with high BMI in a medical weight loss program, depicted on the right panel of this slide, Those who dropped out of treatment had higher levels of internalized weight bias at initial consultation than those who remained in treatment. No other differences between continuers and dropouts were found, including demographics, initial BMI, bariatric surgery history, experienced stigma, or medications prescribed. Internalized weight bias was the only significant predictor of attrition in that study. Collectively, the evidence is clear that medical professionals are not immune to weight stigma. When this stigma is present in healthcare interactions, the quality of patient care suffers. As most stigma-induced barriers to patient care occur in the context of clinician-patient interactions, this means that strategies to reduce weight stigma in healthcare must address how healthcare professionals communicate with patients. Through increased self-awareness and education about weight stigma, respectful language, supportive counseling, and patient-centered approaches, healthcare professionals can remove weight stigma from clinical care. The remainder of this presentation will focus on key strategies to reduce weight stigma and improve care for patients of diverse body sizes. In recent years, multiple national and international medical and scientific organizations have publicly called for increased efforts to address weight stigma, acknowledging the important role of the medical community to help address this problem by improving healthcare professional communication and patient care. So how do we do this? What actionable steps can healthcare professionals take to optimize provision of supportive and compassionate care for people with higher weight? Several key factors are necessary to reduce weight stigma in clinical practice and improve care for patients with high body weight. These include addressing healthcare professionals' assumptions and attitudes about body weight, awareness of weight bias, communication and counseling about weight-related health, and creating an appropriate clinic environment for patients of all body sizes. Let's go through each of these more closely. First, we need to start by examining our own personal assumptions and attitudes about body weight. We all make assumptions, and these can unintentionally reduce the quality of interactions with patients. Consider the following questions. What are your beliefs about body weight and people with obesity? Where do your views about body weight come from? In what ways does your own experience with body weight affect how you view people with obesity? How might your assumptions about body weight affect your interactions with patients? How might your views about obesity affect decision-making with regard to patient care? It's important to challenge assumptions we have that may unintentionally reinforce bias about weight. As part of this process, it's also important to closely examine our attitudes and knowledge about the etiology of obesity, as these beliefs can be linked with expressions of stigma. Research studies indicate that when people attribute the causes of obesity to individual-level characteristics like poor self-discipline or a lack of motivation or willpower, these attributions increase weight stigma. In contrast, recognizing the multiple causes of obesity that include factors beyond an individual's control leads to reductions in weight stigma. So it's essential to understand that obesity has a complex etiology driven by the interaction of multiple contributors beyond an individual's food intake and physical activity, including environmental, genetic, biological, psychological, and behavioral factors and social determinants of health. This knowledge is important for healthcare professionals to acknowledge not only to themselves but to their patients. When patients become aware of the complex factors that are involved in body weight regulation, not only does it help to reduce their self-blame, but it can increase their self-efficacy for making health behavior changes. In addition to examining our assumptions and attitudes, it's important to increase awareness of weight bias. This means educating oneself about the presence of weight bias broadly in our society and more specifically in the healthcare setting, and understanding the ways in which it is harmful to health. It also means being aware of our own implicit assumptions and attitudes about body weight and how these can affect our communication, such as our body language, tone of voice, facial expressions, gestures, eye contact, spatial distance, and comments about weight. We all have unconscious biases and blind spots, which can lead us to make judgments that hinder effective patient care. Through self-reflection, we can become more aware of our biases, which can help us change our behaviors to provide more supportive care to patients of all body sizes. Ask yourself, how do I feel when interacting with patients of different body sizes? How might my views about weight affect my body language, facial expressions, and reactions to patients? How often do I consider my patients' perspectives about weight and their prior experiences? One way of becoming more aware of your implicit bias about weight is to take the Implicit Associations Test, or IAT, at Harvard University's IAT website. This online tool was created by a group of researchers to measure unconscious bias by measuring the time it takes users to form associations between images that reflect concepts and words that reflect evaluations or stereotypes. The test consists of timed tasks of associating as many words and images as possible. The IAT score is based on how long it takes a person, on average, to sort through words with one category of images versus the other set of images. We would say that one has an implicit preference for thin people if they are faster to categorize words when thin people and good words share a response key and fat people and bad words share a response key, relative to the reverse. Taking this IAT can be a helpful exercise to learn about and reflect on implicit bias we have about people of different body sizes. When we are busy or distracted, we're more likely to make biased decisions. Practicing conscious awareness can reduce the impact of unconscious bias on our choices and behaviors. To practice conscious awareness and work toward actionable change, it's helpful to acknowledge and accept that you have bias, to recognize stereotypical thoughts. Try to catch yourself in the moment when a biased thought enters your mind and challenge the thought. Try to replace this thought with new information that has been learned. Solicit feedback from your colleagues about potential blind spots you may have, such as whether certain aspects of your communication may unintentionally reinforce bias. Interact with and listen to people of diverse body sizes and people who challenge common weight stereotypes. Seek out accurate literature, documentaries, stories, and other information that can help you expand your views and consider other perspectives. Continuing to examine our biases through ongoing reflective practice can create new awareness and knowledge that foster changes in our attitudes and behaviors to provide more compassionate patient care. One of the most important factors in optimizing supportive care is how healthcare professionals communicate with patients about body weight. Engaging in patient-centered, respectful, and non-judgmental communication is fundamental. We need to think carefully about whether the language that we use to talk about weight, even if unintentionally or indirectly, contributes to bias or blame. This means considering the moral tone of words that we use and using language that is supportive and empowering to patients. Clinicians sometimes feel unsure about how to communicate about weight-related health with patients. There are 4 key factors that can help foster supportive and respectful communication, which involve using respectful terminology and patient-centered language, focusing on health and health behavior change, not just weight, engaging in active and reflective listening, and implementing motivational interviewing techniques. Each of these important strategies is summarized in the next few slides. First, body weight can be a sensitive topic to discuss, and people have different preferences for the words they feel most comfortable using to describe their weight status or body size. Certain words or phrases to describe body weight can lead patients to feel stigmatized, judged, and blamed. Using words that make patients feel this way can jeopardize important discussions about health. However, people's word preferences can differ according to their sex, race, ethnicity, age, weight status, and prior experiences related to their weight. There is considerable variation in people's word preferences, and the words they feel most comfortable using to describe their weight status or body size aren't always the same. So, what words should we use to talk about weight-related health? Currently, there is not a universally acceptable word or phrase to describe higher weight that everyone is comfortable with. In general, research indicates that people generally prefer neutral words to describe their body weight. Preferred terms typically include weight, high body weight, or unhealthy weight. In contrast, studies show that people generally dislike the words fat or obese. So it's helpful to default to neutral terminology, avoid making assumptions, acknowledge the diversity of preferences that exist, and ask patients for their preferred words when talking with them. First, when beginning a conversation about body weight, ask the patient for permission to discuss their weight. For example, ask, "Could we talk about your weight today?" Or, "Would it be okay if we discuss your weight?" In some cases, it may also be helpful to acknowledge that weight can be a sensitive topic and why you think the discussion may be important to the patient's health before you ask permission. For example, if you're discussing elevated blood pressure, You could say, for some people, elevated blood pressure can be influenced by their weight. I know that it can sometimes be difficult to discuss weight. Could we talk about your weight today? If the patient does not want to talk about weight, respond with empathy and leave the door open for future communication. Saying, that is okay, and I'm here if you would like to talk about this in the future, shows your respect for a patient's decision about their body weight, even if they do not wish to pursue health behavior change or weight loss. If the patient agrees to discuss weight, it's helpful to acknowledge that people have different preferences for terminology and ask them what words they prefer that you use. For example, you can say, people have different preferences when it comes to the words used to describe their body weight. Are there words that you would prefer I use to talk about your weight? What words would you feel most comfortable with as we talk about your weight? If the patient gives permission to discuss weight, it's important to approach this conversation in a patient-centered, non-judgmental, and respectful way. Here are some examples of questions to facilitate this conversation. How are you feeling about your weight? How does your weight affect your quality of life? I'd like to learn more about your experiences with weight and health behaviors. What would be helpful for me to know about? Are there health behavior changes that you would like to make? Let's create a plan together that works for you. Another consideration for patient-centered language is the use of people-first language. People-first language avoids labeling or identifying people by their medical condition, and instead identifies a patient as a person first, followed by their condition. This terminology has been adopted with other illnesses and diseases, such as diabetes, mental illness, and substance use, to help reduce stigma. People-first language for obesity has become an accepted standard endorsed by national medical organizations and is encouraged for communication with patients, clinicians, and other medical personnel when discussing individuals with high body weight. Using people-first language means referring to a patient with obesity or a person who has obesity, rather than identity-first language, such as an obese patient. However, it is important to remember that individual preferences vary, and it is recommended that healthcare professionals ask patients which terms or phrases they prefer when using people-first language. Beyond the words we use to talk about body weight, it's also important to look carefully at how we communicate about eating habits or physical activity, which can unintentionally reinforce weight stigma. For example, talking to patients about making excuses for not sticking to a diet plan or resisting temptations to eat are phrases that can lead patients to feel shame and blame. Consider the following words and how these can be replaced with more supportive language. Instead of talking about a patient's excuses, talk about strategies to minimize triggers. Rather than using words like discipline or self-control, talk about ways for patients to practice healthy habits. Instead of referring to cheating on one's diet plan, discuss situations that create challenges or difficulties in staying on track. Rather than talking about the need to resist temptations to eat, talk about ways to cope with emotions or cravings that influence eating behaviors. And instead of telling patients not to overindulge on food, discuss ways for them to feel satisfied, not deprived. By attending to these aspects of your communication with patients, you can promote more supportive and productive conversations about health. How patients approach, perceive, and react to healthcare encounters can be influenced by their previous experiences in the medical system. Recognize that many patients have implemented lifestyle changes multiple times in the past and have experienced limited weight reduction and weight regain despite their hard work, motivation, and commitment. These experiences often leave patients feeling discouraged, frustrated, and shamed in the medical system. Additionally, patients may have previously experienced weight bias in healthcare. As a result of those experiences, they may be hesitant to discuss weight and anticipate stigma and judgment in healthcare interactions. Respectful, non-judgmental communication is key in helping patients feel supported. Acknowledging patients' prior experiences related to their weight and the distress resulting from those experiences can help you approach conversations with increased sensitivity and compassion. Communicating that you understand the challenges of sustaining weight loss and that you recognize the presence of weight stigma in our society and its damaging impact on health can help validate your patients' experiences and feelings. This can in turn help ease their anxiety, increase trust, and foster more open communication. When engaging in conversations with patients about weight-related health, avoid focusing only on BMI. In 2023, the American Medical Association adopted a policy clarifying the role of BMI as a measure in medicine, noting the limitations of BMI and recommending that BMI be used in conjunction with other valid measures of risk, such as measurements of metabolic factors, waist circumference, and body composition. It's important to discuss health behavior changes in the context of improving health indices, like blood glucose levels, lipids, or blood pressure, rather than emphasizing BMI or weight loss. Similarly, try to emphasize the value of non-scale victories, like improved mobility, quality of life, or cardiometabolic risk factors. Also, be sure to consider the patient's concerns independent of body weight. Explore all causes of a patient's presenting problems and avoid making assumptions that body weight is at the root of their symptoms. Effective listening is essential to patient-centered care as it demonstrates your empathy, support, and understanding of the patient. Active listening involves being fully engaged and attentive to the patient, receiving and interpreting their words, body language, tone of voice, and facial expressions to understand the fullest meaning of their message. When we engage in active listening, we can improve our interpersonal relationships. Reflective listening is a more specialized form of active listening that goes a step further, not only to seek to understand the patient, but to also communicate the idea back to the patient to ensure it was understood correctly. A reflective listener asks questions to the patient and will typically paraphrase or mirror the patient's message back to him or her to confirm understanding. The OARS acronym can help you practice and improve your active and reflective listening with your patients. O stands for open-ended questions, which offers patients the opportunity to share their experiences in their own words and encourages a two-way dialogue to help you understand the patient's perceptions and barriers and to seek clarification. A stands for affirmative statements, to recognize the patient's strengths, help them build confidence, and acknowledge their behaviors that lead in the direction of positive change. R stands for reflective listening, where paraphrasing helps confirm you understand the patient's statements. And S stands for summary statements, which are helpful to communicate a transition point in the conversation to check for correct understanding and as a step towards change. Using motivational interviewing techniques can support patients of all body sizes in making health behavior changes. Through a goal-oriented, patient-centered, and interactive listening style, motivational interviewing aims to understand the patient's perspective, reduce patient ambivalence about health behavior change, promote patient motivation and confidence in achieving goals, identify potential barriers, and assist the patient to identify their own solutions. You can use motivational interviewing questions to assess a patient's readiness for making health behavior changes and to tailor your communication to patients based on what stage of change they're in. For example, you can support a patient in the contemplation stage by helping them identify the pros and cons of behavior change. For a patient in the preparation stage, you can help them develop relevant behavioral goals and identify sources of support as they begin to implement their plans. It's also a helpful approach for collaborating with the patient to come up with relevant and realistic health behavior goals. Also referred to as SMART goals, these are goals that are specific, measurable, attainable, relevant, and time-bound. To summarize, let's review what to avoid and what to prioritize to facilitate supportive and respectful communication with patients. When you approach conversations about weight-related health with patients, avoid focusing only on BMI and weight loss. Avoid oversimplifying the etiology of obesity and body weight regulation. Avoid phrases like calories in, calories out, or eat less and exercise more. Avoid making assumptions about a patient's current or past health behaviors. Don't assume that the patient wants to lose weight. Avoid weight-related labels or terminology that may evoke patient discomfort or perceived judgment. And avoid language which implies blame or judgment on patients for their weight. Instead, prioritize the following in your communication with patients. Establish rapport and trust. Use sensitive, patient-centered language. Ask the patient's permission to discuss weight. Default to neutral words like weight and ask patients what words they prefer to discuss their weight. Engage in reflective, active listening. Prioritize health behaviors, health outcomes, and quality of life rather than BMI or body weight. Focus on the value of non-scale victories. Discuss the benefits of healthy behaviors and how they impact quality of life and health status. Acknowledge the complex etiology of obesity. Respect the patient's freedom to make their own decision about whether or not they want to lose weight. Collaborate with your patients to identify realistic and sustainable health behavior goals. And keep the door open for future communication and ongoing support. As you implement these strategies into your interactions with patients, consider other factors that can either hinder or promote supportive and respectful communication with patients. Don't forget to recognize your own attitudes and assumptions. Practice conscious awareness strategies to reduce the impact of unconscious bias on your communication with patients. Ensure that the environment is welcoming and comfortable for patients with higher weight, including the availability of appropriately sized medical equipment and comfortable seating for patients of all body sizes. Try to set aside time for discussion so that patients will not feel rushed. If time is short, consider scheduling a dedicated visit to discuss weight-related care or spend time across several visits. Beyond engaging in strategies to improve your attitudes and awareness and communication, it's important to ensure that your clinic or medical office is well equipped to accommodate and accurately assess patients with larger body sizes. Providing a safe and welcoming environment can improve patient care, reduce patient experiences of stigma, and eliminate unnecessary barriers that may otherwise deter patients from seeking care. This means considering the medical equipment and facilities, procedures for weighing patients, and staff training and education. First, ensure that appropriate facilities and medical equipment are available to accommodate and accurately assess patients with high weight. This includes the following: large, sturdy chairs or benches in waiting areas and examination rooms that can accommodate patients and visitors with larger body sizes. Sturdy step stools in examination rooms. Large examination tables with proper width and weight capacity. Extra large examination gowns in every examination room. Extra large adult-size blood pressure cuffs in every examination room. High-capacity scales with handles for support that can measure over 500 pounds. Extra long phlebotomy needles and tourniquets. Floor-mounted toilets. Bathrooms with grab bars and split lavatory seats. And doors and hallways that accommodate large-size wheelchairs, walkers, and scooters. For many patients, being weighed creates feelings of anxiety, shame, and embarrassment. Additionally, patients may have had stigmatizing healthcare experiences in the past and feel uncomfortable being weighed. Facing the scale can be such a negative experience that it becomes a reason for patients to avoid seeking healthcare. So it's important to approach weighing procedures in a sensitive and respectful manner and to ensure that the scale is located in an area where the patient can be weighed with privacy and confidentiality. Before measuring a patient's weight, review the patient's chart for their weight history, noting changes in weight between visits and determining whether the patient needs to be weighed at the appointment. The answer may be yes, but there are times where weighing is not necessary. If a patient's weight needs to be measured, it is recommended to first ask the patient's permission, such as asking, "May we measure your weight today?" Be respectful if the patient decides not to be weighed. For patients who give permission to be weighed, offer them the option for blind weighing, facing away from the scale if they prefer. Record the patient's weight without judgment and without negative comments or facial expressions. Then ask the patient whether or not they would like to be informed of how much they weigh. Attention to these details and ensuring that the healthcare team is trained on implementing sensitive weighing procedures can create more supportive and comfortable experiences for patients. Training and educating medical staff and clinicians can help minimize weight stigma in healthcare encounters with patients. Provide in-service education on weight bias for all personnel, including healthcare professionals, medical assistants, front desk employees, and back office workers. And provide training on strategies to foster supportive and respectful communication with patients of all body sizes. In summary, there are tangible opportunities for health professionals to promote more supportive patient care for patients of high body weight. We can increase awareness in ourselves and our colleagues about weight stigma and its harmful health consequences. We can practice and implement sensitive and respectful communication about weight-related health with patients and colleagues. We can engage in clinical strategies that support patients in their health behavior change, and we can advocate to help create a more supportive healthcare environment for people of all body sizes. Much of the content in this presentation is available on our website, www.supportiveobesitycare.org, as downloadable handouts, podcasts, and other videos. These resources provide more information about weight stigma, its impact on health, and strategies to implement compassionate and respectful care to patients of higher weight, and are suitable for educating medical staff and healthcare professionals across diverse units and disciplines. We encourage you to share these resources with your colleagues, staff, and trainees, and to use these tools to help optimize supportive healthcare delivery to your patients.